Okay, so again, thank you for the opportunity to. I know why I'm thanking him. Half my faculty's here. I'm financially supporting this entire meeting. So thank you for the. You should be thanking me for the opportunity to support this. And it's, so anyway, what I want you to think about what he just showed you. In a cardiac arrest situation, the guy who's doing the CPR is you. They are the perfusionist. They are there to provide blood flow to the brain. And yet, if you took that picture of the junior faculty member, happened to be one of the cardiology fellows, doing this, it looked like the patient was having CPR performed, but they weren't perfusing the brain. That patient that I told you about that went on bypass through a type A dissection was on bypass, but they weren't perfusing the brain. The outcomes are going to be exactly the same, and I'm going to submit to you that the only thing that's out there that gives you instantaneous knowledge that lets you correct that situation, identifying an intracerebral embolus and going straight basically to neurosalvage, that patient under normal circumstances would have gone to the ICU, would have woken up 5 hours later, would have had a stroke. And the question to the surgeon or the interventionist would be, when did that happen? And you haven't a clue when it happened. If you don't know when it happened, you can't fix it. So that's kind of what we're going to focus on a little bit, is how can we know when the stroke happened? And some of the new stroke classifications may throw you a bone in the surgical aortic valve world. That's what we're going to talk about. So I'm going to go through these fairly rapidly. There's quite a bit of evidence out there. Intracerebral embolization occurs in any kind of intervention that involves the ascending aorta, the coronary arteries, and the valve. And a lot of that, of course, is not a whole lot of consequence. But some patients basically have frank stroke. Some patients, pump head has been kind of around for a long time. Nobody exactly knows what it means. And there may be some insight into what's going on. And one of the things that's really focusing on this now is a new stroke classification system that came out from Lansky. And they represent what's called the NeuroArc, the Neurological Academic Research Consortium. And if you look basically through that list of people who have endorsed this includes cardiologists, neurologists. Anytime you get the stroke neurologist involved, you're done at that point in time, because they look at stroke in a whole different way from you and I, but they may be right. So you need to be aware of the new stroke classification from NeuroArc published by Lansky, and I'm going to highlight some of the features on this. And so what they've basically said is that the primary mechanism, they're talking about surgical procedures and TAVR. Primary mechanism of procedure-related stroke is focal or multifocal embolization during the instrumentation or surgical manipulation. Secondly, it can be from diffuse cerebral hyperperfusion. That's probably what happened in the dissection patient that we talked about. And so the outcome of all of these things is impairment of neurologic function. And you don't have to read all of this stuff, but basically what they've done is classify this into like 4 different types. Type 1 is lesion in the brain, clinical sequelae, hemiplegia, dysphagia, or whatever it is. I don't think anybody's going to argue really about that. But what they've now done is call a type 2 stroke. This is a very profound change that has actually taken place. And what this is covert central nervous system brain injury, could be spinal cord, creating an acutely symptomatic brain in the absence of clinical symptoms. Now, you just heard some data that says 60-70% of people with TAVR have lesions in their brain. And the general approach to this is no big deal, no consequence, goes away after a period of time. Well, what they're going to basically now say is that equals dead brain. I know you can't afford too many of those neurons to go down at this particular point in time, Joe, and so I'm not sure many of us will. We'll explore that basically a little bit more. And so what they're saying is that they're talking about covert CNS infarction. This is dead brain in your head without necessarily rising in the short term to clinical manifestations that we would recognize as stroke. And so now let's talk about how Dr. Skipper is going to approach that TAVR patient tomorrow and get consent. And they're going to say, well, consequences are put the valve in, you get bleeding in the groin, and there's a risk of having stroke. In the stroke, in my definition, it's probably only the 3-4%, but let's say we have this new stroke definition. Mrs. Smith, there's an 80% chance that you're going to have a stroke from this. Oh, by the way, it's not really an important stroke. It's kind of not that. It's not the kind of stroke that I really worry about. And you're going to be there for the next 3 hours trying to explain why you think this stroke is not important. But this classification system now says you're killing my brain basically in doing this. And so this is going to be important. And this is moving to an era that says you can't run these clinical trials based upon type 1 stroke, which is kind of what everybody agrees on, dead brain and something not working properly. You're going to have to run imaging studies. This has profound implications for everybody who's kind of involved in this field, because they're going to mandate that you have some sort of evaluation of the amount of cells you're killing, in the brain. And so this is kind of the proposed change in the way that these studies are actually going to be involved. And this makes it very expensive if we're going to do these neuroimaging studies, but I think we're going to be forced into it. And if you look at the neurological outcomes, type 3 I didn't talk about, which is kind of, when the patient basically has confusional states, but the majority of these events that are happening, and we're talking about TAVR, but the reality is you don't know what it is with coronary bypass, you don't know what it is with arch endograft, and I'm sure it's off the charts when we're doing that, or what it is with an open surgical valve. But in the future, you may have to actually start looking at this basically a little bit more. And so these MRI endpoints, which is the main way that you're going to evaluate this, are going to be starting to be built into these clinical trials, and look at cognitive endpoints to see whether or not there are. It may be just the methodologies we've used to look at clinical manifestations have been too crude to actually pick up really what's going on. And so this actually comes from a webcast that Dr. Gramy and I actually did, because whenever there's an observation like this, now there's another opportunity. And that opportunity that's emerging is started off talking about embolization protection devices. And so all of the big device companies are now highly tuned into the fact that if you're going to start talking about an 80% stroke rate, you got to figure out how you're going to reduce this. And if you reduce it with TAVR, all of these things may have relevance to what we do, in an operation. So go straight to that table. It says the procedure: surgical valve, clinical stroke 0.5 to 6.2%, silent stroke, we'll talk a little bit about what that is, somewhere in the order of 38 to 65%. So are you going to sign up for a surgical operation tomorrow? That's how you got a 65% stroke rate that's associated with it. Whew, take my chances. TAVR is probably even higher. And the significance of that we're going to explore. So what's a stroke? Clinical manifestations of a stroke, of course, we all know may range from something that seems trivial to something that may be very severe. And you can see what the American Heart and the Stroke Association guidelines basically are. But this microinfarction concept really wasn't even appreciated until after diffusion-weighted MRI imaging came to be. Now, the reason I can tie this to what Zolt has just talked to you a little bit about is, once again, the question is, show me unimportant strokes that are going up into your brain, and I'll show you that you're just not evaluating it properly to be able to understand that. So, once again, to summarize, the NeuroArt definition is type 1 stroke, no argument. Type 2, silent asymptomatic stroke, brackets, cortical necrosis. And for every 1 cubic millimeter of diffusion MRI positive lesions in your brain equals 50,000 dead brain cells and 5 million synapses that are affected. The average volume after a TAVR is 7.3 cubic millimeters. That's 7 times 50,000 and 7 times 5 million. And it may be that the connections are more important than the cells themselves. So it may be that the functional manifestations of this are just something that we've really not been detecting. And this is just looking at the reports of clinical stroke rate at 30 days. No question it's come down basically with TAVR. They've actually done a pretty good job basically in bringing that down. So if you're the guy who makes the TAVR, and a patient basically is either sedated or asleep when they're having the TAVR, and then they waken up and they've got a stroke, the question is, what do you fix? Because that event may have happened during the passage of the guide wire for the first time. It may have happened because when you injected the contrast, you didn't get the bubbles out of it. It may have happened during the passage of the device over the aortic arch. Or it may have happened during deployment or post-dilation. And the challenge basically is for a device company is you go, okay, you got a stroke rate, let's say it's 7-8% clinical event rate, fix something. They're going to say, well, fix what? I don't even know what to fix because, I can't fix the whole operation. And you guess when it happened. And I submit to you that when you're providing perfusion services for a patient who has a stroke post-operatively, you don't have any idea basically when it actually happened. And that's why we have been particularly interested in transcranial Doppler, because it tells us what is going on in your head. The middle cerebral artery is the target organ for looking at and trying to evaluate. And I'm on a mission to say that you should basically figure out how to do TCD. It's not that hard. And that the perfusionist is because you're used to flow and you're used to waveforms, that you can basically build this into your armamentarium of what's actually going on, and it will help troubleshoot when these events are actually happening basically intraoperatively, and we'll let the surgeon respond to that and ultimately reduce the rate basically of these events that are actually taking place. So let's talk a little bit about MRI. This is just to show that embolization protection devices will reduce the incidence of diffusion-weighted MRI imaging. And so there probably is value in that. It's not basically a complete pass, because you got to put the device in, you got to deploy it, and that in itself can be embologenic. Zoe actually did the monitoring for the first Umbrella devices. Umbrella is a really interesting little story, because it was invented by a vascular surgeon. And he was working for University of Pennsylvania at that time. And I shouldn't say it was invented by the vascular surgeon, because when the patents were submitted, it was invented by his wife. And so the University of Pennsylvania went, no, wait a minute. You work for us. She doesn't work for us. How could she have actually invented this? And so they actually tried to get the patent slipped in under the wife's name, avoid paying the royalties to the university, got sued for it, and ended up losing. And the University of Pennsylvania now owns the patent space on some of these embolization protection devices. So anyway, the embolization protection devices have different porosities, different ways you've actually got to get them in there, but there's a lot of evidence that will actually reduce the incidence of that happening. And these are just some of the concepts. You may hear a little bit more about this from Dr. Cohen tomorrow, because he's been involved in the development of some of these devices. But they got to be simple, they got to be effective, they can't cause more trouble than you're trying to avoid. And so there's a lot of different clinical trials that are currently looking at that. But let's go back to this concept of type 2 stroke. Diffusion-weighted MRI image basically looks at water leakage out of damaged cells in your brain, and it happens very early on. That's why the stroke neurologists use this, because it will be positive faster than a CAT scan will. And so when you look basically at the occipital area, let's see if I can get Joe's. This is designed for knocking helicopters out of the sky, I believe. And so this is an example of the sort of things that you can have. When you see it on both hemispheres in multiple different areas, it's embolization really that is actually taking place. And that is what is being described now as this represents dead cells that are actually occurring there. And again, it may be a significant number of dead cells that are going to be in there. And so we're going to be held to that standard of trying to reduce this. You can't reduce this very easily unless you have a real-time way of monitoring this. So for example, one of the criticisms you hear of transcranial Doppler is too sensitive, shows me stuff that's not important. Number one, that may be completely false premise, and this may be the right answer, that none of that is inconsequential. Second part is, I can't do anything about it. I'm on pump through the right axillary, and we're basically got no flow in the left hemisphere. Joe told me there's nothing you can do about it. Really? So if I put an ECMO cannula in your left groin and there's no flow down the left leg, you consult me to put a sheath in your left femoral artery so that we can put it on the pump and we can flow down your left leg. And you can't do that in a carotid artery when there's no flow to the opposite side of the brain. That's bull, and much more important. So first of all, you've got to recognize that there's a problem. Then we'll figure out the strategies by which we get you perfusion to the important part of this. So these may be very important components. The second part of this is that if you basically do a complex procedure, and during the phase of valve deployment, there is no embolization, and the patient wakens up with a stroke, I will guarantee you it didn't happen during that phase, because it is highly sensitive. It may show you emboli that might not be of importance, but when there's no emboli, it is not happening. So it helps you break these procedures down in the component parts and understanding what is going on with that particular patient. I'm going to give Joe some credit. I haven't been beating on him all this time. I'm going to give you some credit. I mean, and this was an example. We set up this perfusion circuit in Houston, and we injected air into the circuit that we were using for training on this. We actually had a whole circuit set up, and we injected air into it, and you could see the air coming up in the head of the model. but it kept embolizing. And we were like, why would it still be embolizing? Just there's cavities, there's bubbles in the connectors, and he picks it up and goes boom, 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 boom. Psh, you see all this massive, all these bubbles fragment, goes up in the head, and then it clears. So it was a combination of us basically seeing ongoing embolization, him understanding the nuances of the circuit of where air can get trapped, and then basically intervening to actually prevent that really from happening. So let's kind of keep on going. So this is just really about building clinical trials and how to monitor these. I think you're going to have to do this in surgical valves and things going forward, and you may have a significant advantage here. And you can measure the location, you can measure the volume, and get some understanding of the amount of brain that is being damaged when we're actually in here. So I'm going to pull out of this for 1 minute and take you ahead. I've only got 5 minutes left, so let me just go on a little bit further and show you basically some examples. So I'm going to talk a little bit about transcranial Doppler and make this simple. I pride myself in simplifying what Zoe is telling you. You put a transcranial Doppler probe on your head and you fire a beam along an axis. It looks at the ipsilateral middle cerebral artery, and that's at a depth of about 50 millimeters. Blood is flowing towards that probe. It is represented as red. When you go on to the anterior cerebral artery on the same side, blood is flowing away from the probe, and that's a depth of, 65 millimeters? That is blue. Sometimes you can even cross the midline and look at the anterior cerebral artery on the other side. And that is now red again because blood is flowing towards the probe. So it tells you the depth, tells you what artery you're looking at. It tells you basically what the flow velocities are in it. It tells you whether it changes flow velocity, and it tells you whether there's embolization occurring into those territories. It's not that complicated. It can be very complicated, but on a simple level, we need to know direction, and we need to know velocity, and we need to know ultimately whether there's any embolization actually occurring into it. I think the valve passing over the aortic arch, I think he's basically showed you. Here's what really convinced us. And so we are on the point that we just bring in a neurologist from Spain. We're going to do this in every open heart procedure, in the operating room really for the next year. Because this is Rationale again. As you go through this is real time what's going on in the patient's head. Okay, this is the right side, left side. This is going to be the middle cerebral artery. By drawing that line on the middle cerebral artery, it gives us the Doppler signal, the flow velocity waveform from that artery. What's going to happen here is he's going to bring in that CO2 blower. The artery is open, and you're going to watch the head when this comes in. Now see, immediately he puts a CO2 blower on an open coronary artery, and you see embolization occurring up in the head. What's the remedial action? He readjusts the stabilizer to occlude it, but you would not even have known that this was happening, basically, had we not actually been doing real-time monitoring. I did this, and this is what happened up in the head. That's really why I think this is kind of the gold standard in being able to look at that. So to summarize that, it allows you non-invasive evaluation of the intracranial arteries. It shows, I'm going to show you, basically keep it simple, stupid, I guess, is some of the challenges are, it has been highly dependent on a few experts who can do this, and Zoe happens to be both an expert in TCD and in STD, but we value him in the department basically for the former. Occasionally we need him for the latter. And so it shows you it's been dependent upon the operator, but I will show you the more ways in which we think we can make that expertise basically much more widely available. What does it measure? It measures, think of it as you can choose an artery, middle cerebral artery, anterior cerebral artery, flow velocity, flow direction, and emboli. It lets you look at essentially an axis, middle cerebral artery, same side anterior cerebral, contralateral anterior cerebral, and there are also ways basically at looking at your posterior circulation. There is nothing that will allow you to be able to say instantaneously this is what is going on in the arteries in the head when I am working on the arteries of the heart. And I think this is well within the capability of perfusionists to add this into their armamentarium. It will allow you to intervene early, to modify your strategies, and if we are going to be held to a standard of reducing the amount of type 2 CNS infarction that is out there, then I know of no other technology that's going to allow you to really try and approach that in a methodological way. Thank you very much again for the opportunity to talk to you.